going on, podcasting world? Back for another episode of the Core Consult RX podcast. We're getting ever so close to episode 100.
We are. We're going to do a episode 100 extravaganza.
Obviously. Just don't know what that's going to entail yet.
Maybe we can do a two-parter on something hard.
Pyrotechnic show.
Okay, we could do that.
Or just a hard topic.
You could probably make that work with your lighting situation right now.
Maybe.
I mean, you just had some fire.
Right. That's it. That's all you got to do.
Yeah,
burn my house down. And that was how the podcast ended.
That is when we moved into a off-campus studio.
Right.
Yeah, rental.
Campus. And also my wife.
Which is actually a rental unit, 10 by 10.
It's a storage unit. Man, so Cole and I were actually just talking before we started recording because he made the gross misstep of listening to episode 1 of our own podcast just to kind of see what it was like back then. And he said within 1 second of him talking, he started cringing.
Yeah, in my mind, I thought we did really well. We researched it and we prepared. We even had a junk episode from before that we trashed. And so that was technically our second episode. And my first line was just so terrible for those who go back. So I always recommend that people listen to the first episode. It's great. It was hypertension. I don't think I'm going to recommend that anymore.
It's no longer a recommendation.
Start with the old stuff, and then once you like us, then go back to the beginning.
So start with the new stuff. Like the newest.
Okay, yeah, sorry. Start with the new stuff, and then when you like us, go back to the beginning.
That's a good point.
Yeah.
So, yeah. See, I knew it was a disaster back then. That's why I never listened to those episodes.
So when we're at episode 1,000... we can listen to episode 100 and see how far we've come.
Hopefully we're in a much bigger studio by then.
Probably be, in like November.
Probably.
Much bigger studio. Were you moving out? We're going to purchase something?
Well, if we get to 1 million, would you say 1 million?
1,000.
1,000, never mind.
100 million episodes.
Yes. Dude, but yeah, I remember when we recorded that very first episode, we were kind of like, nah, this isn't going to happen. We just trashed that one and started over.
Well, it was an introduction.
That was the warm-up.
It was an introduction to ourselves, and I'm horrible at talking about myself. I actually hate talking about myself. So I'm glad this isn't a podcast on the lives of Mike and Cole.
This is extremely boring, by the way.
So I have a lot going on. I have a slight follow-up to our most recent episode.
What you got?
Which is doing well, by the way. Coronavirus episode. They've named it now. Did you see that?
Yeah, I did.
Yeah, the COVID-19 is what they're calling it. So
sounds like an Arnold Schwarzenegger movie.
Okay, is that what it sounds like?
Yeah, I guess.
COVID, so COVID, C-O-V-I is coronavirus, of course. D is disease. And then 19 is its year of origin, 2019. So
the year that will live in infamy.
Yeah, it doesn't have any fun like SARS or MERS. Maybe
SARS sounds a lot more intimidating.
Maybe if it causes something like that, they'll add that on at the beginning and it'll be like SARS COVID-19.
Yeah. It's the sequel. Mm-hmm. Man, so what are we talking about today?
We are talking about male hypogonadism with an emphasis on testosterone. Right?
Absolutely.
We're just going to call it hypogonadism, but females have that too. And we're just going to touch. I think we'll have enough trouble touching on the male stuff. So.
And so this actually, I got a message from one of our listeners named Derek, who is doing pre-farm out in Utah and hopes to go to pharmacy school after that. Reached out to me over Instagram and told me that he wanted to give me a couple ideas for episode topics and things like that. And one of them was testosterone, and so I told him we'd start with that one and go from there. But Derek, man, thank you so much for reaching out. Thanks for listening. So. Hope this is what you're looking for, but we'll see. We won't know till the end of it anyway.
Right.
All right. What do you want to start with this? You said you had some updates or background or something, right?
Well, I guess this could be saved for later on, but I'll just throw it in now because we'll be talking a lot about testosterone and testosterone supplementation. It first started, which they had been trying to do like testes transplantations for the last, or I guess in the 1700s, the 1800s, they were transplanting human testes onto other people. They were transplanting animals' testes onto other people. So trial and error, it makes you really glad you weren't around in that time. Back then, there were a lot of people who had been castrated for various reasons, whether it was to be a choir boy or to be someone trusted in the high court of some land. I guess they just have more wisdom because they're not clouded by testosterone and hormones. So anyways, 1935 was when Inrest Locker, that's what I'm going with, isolated testosterone from bull testes in Amsterdam. And then the same year, testosterone was chemically synthesized independently by another guy. So that was kind of the start of where we get our testosterone supplementation, and our anabolic type things is what came out of that as well. They tried oral testosterone for a while. Turns out that doesn't work very well because it just kills your liver. Even though if you go to other countries, you could probably even order it from like Canada. You could order oral testosterone and use it. But we'll talk a little more about that as we get into the testosterone stuff. So that was just a little history. Now we can talk about hypogonadism.
Cool. So I guess let's just start with, testosterone, endogenous testosterone, like what that is to begin with. So obviously male sex hormone, but also found in females. And it's basically manufactured in the testes, but it's going to be influenced directly by luteinizing hormone, as well as follicle stimulating hormone that are, and you get this those are produced in the pituitary, but you get this hypothalamus, anterior pituitary, and testes kind of feedback loop going. And so when you have these increasing levels of follicle stimulating hormone, luteinizing hormone, you signal for testosterone release. And that can also lead to a negative feedback inhibition of those hormones, as well as gonadotropin releasing hormone as well.
Right.
And so all that kind of is the reason why, when younger boys are going through like puberty and all that, they start having the hormone changes and stuff, and testosterone is kind of driving that. Obviously increases spermatogenesis and all that fun stuff. But as we get older, then testosterone levels tend to decrease. So after about 40, depending on which, site you're looking at, usually there's consensus is around 40, your testosterone levels start to decline. And, a lot of times when you look at like overall data with 60-year-olds and more, it's a good majority of them have decreased levels of testosterone.
I saw one stat, 80 years old, 80% of people who are 80 years old, men who are 80 years old, have low T. So it's definitely age-related, and that's going to be your primary risk factor in a patient who is aged. That you're considering. If they're younger, you might be looking at other causes. So we'll get into that. But just like Mike said, luteinizing hormone stimulates Leydig cells to secrete testosterone, whereas the follicle stimulating hormone is more necessary for like tubular growth. There's a couple, so with all that in mind, like Mike was talking about, there's a couple of modalities to acquire hypogonadism. Obviously a condition where little or not enough hormone is produced by the testes. It can be hypergonadotropic. This is called primary, where the gonads fail, or it can be hypogonadotropic, which involves more of the pathway that Mike was talking about. So there might be an issue with the pituitary secreting luteinizing hormone or follicle stimulating hormone, or somewhere in that process you have an issue, whether it's a mass or something congenital or genetic. We're mostly going to be talking about men as opposed to pre-puberty hypogonadism. That can be caused by various syndromes, like Klinefelter's, I believe, is the most common, but there's other ones. In men over 40, it's mostly going to be age-related, though that doesn't mean that you don't want to look for other things that it could be, but that's kind of what we're going to be talking about when we talk about supplementation.
And the universal kind of lab value as far as what would make someone or give someone the diagnosis of hypogonadism, there's not a set lab value, but basically a lot of the literature will say less than 300 nanograms per deciliter of testosterone. So the reference range, again, depending on what you look at, is going to be between 300, some say 800 to 800, some say 300 to 1,000, depends on what you look. If you have 1,000 nanograms per deciliter of testosterone in your system,
pumping it.
Yeah, you're probably pretty aggressive guy. Yes, that's some pretty high levels.
Yeah, the goal is to kind of get back in that range when you're treating, with the symptoms and things being somewhat secondary, though that's mostly what your patients are going to be worried about. So there's going to be symptoms of lack of energy, you're going to have fatigue, decreased sexual function. A lot of times you might have a guy who is a little bit reluctant to come in. They might even have their wife with them because there's issues with decreased libido. Though a lot of men are going to be concerned about ED, That's more of a neurovascular issue, not so much with testosterone. The libido, so lack of sexual interest, would be a testosterone issue, and supplementation and getting back into reference range would probably improve that. With ED, you're still probably going to be looking at PDE5 inhibitors to be your primary go-to, and you might want to look at their history, like smoking history and history of cardiovascular disease for that sort of thing. Diabetes, yeah, and diabetes can lead to hypogonadism in general as well, yeah.
And that's a good point about the ED, because there have been a couple like comparative studies where they've looked at testosterone versus Viagra or Cialis or something like that, and the phosphodiesterase 5 inhibitors seem to do much better.
Yeah.
So yeah, that's good. So kind of looking at, again, kind of the testosterone as a whole, I feel like especially the dude listeners have, when we think of testosterone, a lot of times we think of the huge muscular guy at the gym because of the anabolic properties of testosterone. And so we're going to talk about the anabolic as well as the androgenic and kind of separate those out a little bit. But just to kind of give you, I guess, an idea of like what's going on there with the muscle growth and all that. So testosterone goes into the cytosol of different cells, particularly in that case, myocytes, muscle cells, and binds to the receptors, creates this complex that then basically just activates all this different very specific messenger RNA to increase transcription, increasing this huge rate of protein synthesis. And in those muscle cells in particular, it's actin and myosin, and that ramp up of that increase in protein seems to be where the muscle growth and buildup actually comes from. That being said, just because someone uses testosterone, especially in the case of actually having it monitored by a licensed physician and not some guy that you met at the gym, the men that have low T levels usually look like normal people when they take testosterone. I think there's this misconception that all of a sudden if you take testosterone, you're going to turn into the Hulk. In fact, I'm going to call him out on this because it's fine. But my dad...
I thought you were going to call it the Hulk.
No, I'm not crazy. So my dad got... he had tried it for a little bit.
Mike Smash.
And he tried regular testosterone. He literally asked me, he's like... I'm not getting any bigger. My muscles aren't getting any bigger. I'm working out every day. And, granted he was, but I was explaining, I was like, when you see those guys on TV, one, they're taking insane amounts a lot of times. And they're also lifting weights and eating enormous amounts of food, like a good 7 to 8 hours a day as well, because that's like their job.
Right.
So very different
it's not magic.
results. It's definitely not magic. It's not, you're not going to take that and then all of a sudden become insanely strong or
and
a
then
phenomenal
there
athlete.
are negatives to that, especially. So if your testosterone is normal and you start supplementing, then you could have negative effects.
Absolutely.
Extra testosterone can be esteratized into estrogen, and you can have, increased acne, oily skin, gynecomastia, infertility that can last a long time, if not be permanent. Didn't you do a Grand Rounds topic on something to do with testosterone?
Mine was on a selective androgen receptor modulator, which can increase like
so it's like a SERM,
yeah,
but for androgen.
for androgen. So it can like increase like testosterone levels without actually being testosterone itself. But yeah,
interesting.
I don't think last time I checked, it was in phase 2 clinical trials. Whenever I looked at it, and then I don't know that it ever went anywhere from there.
Right.
But so we mentioned anabolic, that's the muscle growth, all that fun stuff. Now the not so fun stuff is the androgenic response. So you have androgen receptors in the tissue and things like that. So when testosterone interacts with those, you get these androgenic responses, which, like Cole was saying, can increase, things like hair growth, acne. You can have issues with gynecomastia, things like that over time. So you can have all these negative effects from that. And that's basically because you have testosterone can go through 2 different paths. So testosterone can be converted into dihydrotestosterone, which is that 5-alpha reductase enzyme that we talk about when we're talking about like BPH for prostate or even hair loss in men. That enzyme is converting that regular free testosterone into that dihydrotestosterone, which then has a lot more androgenic effects when it binds to that androgen receptor. And so And then the other option, obviously, is testosterone can be converted into estrogen by the enzyme aromatase. So testosterone, as far as the androgenic side effects, those certain androgenic receptors that kind of lead to that response happen to be located in things like the skin, which is where you get that increased sebum production, increased acne in the scalp. And so a lot of times we'll have issues with hair, and that's one of the reasons why we can use a 5-alpha reductase inhibitor to kind of stop some of that hair loss in men who are balding naturally, and then also in the prostate as well, and that's where we can get issues with enlarged prostate sizes and things like that.
Yeah. Speaking of that, when you're considering treating somebody for low T and supplementing, that is stuff you want to look for. If they have a history of cardiovascular disease, there are kind of mixed reviews as to how important that is, but definitely something to consider, especially if they're younger and already have a history of cardiovascular disease. If they have increased PSA or if they have prostate issues, that might be somebody you don't really want to use this in. And I was also reading that sleep apnea, obstructive sleep apnea might be one as well. You usually would want to try to treat that before supplementing to make sure that it's a true low T, or that they don't have other issues going on that might cause that and might cause issues from hypoxia from their apneic events, can increase risk for something like a stroke with low T.
Mm-hmm. So definitely a lot of potential side effects, and now we're just now getting to the point where we're having a lot of these studies that'll come out that have kind of looked at those cardiovascular benefits. Because before we were just kind of like, hope it goes well.
Yeah.
And, the other piece of that is because we knew that we saw some of these like athletes and stuff that we knew were abusing testosterone, having, MIs and strokes and things like that very early in life. And like, you still will see that today sometimes with some of the big bodybuilders and stuff. But, now the great question is, and we're starting to get answers, but if we use the testosterone in a reasonable dose, in a normal dose, in someone who's got low T, is that cardiovascular risk still actually there long term, or is it only in patients who are using crazy high doses or have cardiovascular disease? So something we just got to keep watching on.
Right. So if you're looking to diagnose somebody with this, we mentioned some of the symptoms of fatigue and potential lack of libido. Other things, you might inquire about the rate of their beard growth. If it's sparse or growing slower, they might, notice that they feel weaker, muscle strength, or they might just have lost a little bit of muscle mass, even though they're doing the same amount of activity. Along with that, the guidelines do recommend measuring testosterone, like we said, on at least 2 occasions. I believe in the morning, maybe sometime between 7 and 10 a.m. would probably be the best time. That's going to be around the peak of their testosterone, because testosterone has diurnal variation. So getting a morning sample is recommended. If they have the symptoms and you also have one level with low T, you're going to want to repeat that just to confirm, and probably then you're going to order some other levels like LH and FSH, maybe even a prolactin, to make sure that there's not other things going on, or even not to just go ahead and start treating without trying to figure out the underlying cause. If they're older, above 40 or 50, it's probably age-related. But if they're younger, you definitely want to look at other things like masses on the pituitary, maybe even some genetic or congenital factor that they carried with them throughout puberty into adulthood. So just make sure you're looking out for other things it could be.
So if we do decide to treat someone with testosterone, at this point, we have a lot of options. We used to have, injectables, and that's kind of where it started. And we've gotten more elaborate from there with topicals and patches, and now back to orals and things like that. So a lot of different formulations and options for your patients. Basically, if you starting with just regular testosterone by itself, it has a certain half-life and how quickly it's released from tissues and things like that. So one of the kind of main objectives for some of the people who were designing the drugs were to take these ester groups and make different formulations to add on to the testosterone molecule, which would then basically increase the amount of time or decrease rather how quickly it was released from the tissue, and would be allowed to stay in the system longer, and you have to dose it less and all that. So like testosterone propionate, cypionate, and and phthalate. The three that we definitely will, see kind of like even in like retail settings that our patients will be on that are injectable versions. And those are basically just testosterone esters in different shapes and forms.
And there are other salt forms too that aren't used, like acetate, phenylpropionate, isocaproate, caproate, all those. Undecanoate is frequently the oral version, which you mentioned that they're coming back to oral. So the one that was approved last year, I believe it's called Jatenzo. Yeah, Jatenzo. Though not approved for age-related low T, it's mostly for prepubescent congenital disorders supplementing testosterone. But I already mentioned that the reason you can't use it is liver toxicity, liver cancer, that sort of thing.
Right.
Usually.
And so the only time we see anything other than the new formulation that just came out, but anytime we don't see oral testosterone before that was actually usually being used to treat women. So it was the methyl.
Yeah, the methyl.
Testosterone. But just like Cole said, that methyl group basically allows for that first pass metabolism, and you get really bad increases in liver toxicity and things like that. But the reason why that's still used in usually in postmenopausal women that have like vasomotor symptoms is because the methyl testosterone, when it's metabolized by that enzyme aromatase, instead of turning testosterone to regular estrogen, you get a very, very potent estrogen that's called 17-alpha methyl estradiol, and that is much more potent than regular estrogen and can help in that regard. So if somebody's on estrogen or progesterone therapy and they add on methyl testosterone, that's kind of the thought process behind it.
That's like that EEMT drug that you dispense.
Yeah.
Estrogen and methyl testosterone. So cypionate seems to be the most common injectable form, and that's probably because it lasts a long time as opposed to some other salt forms when injected might not last long enough. That's why usually you only have to inject every week or every 2 weeks or even every 10 days, depending on the situation. There are also transdermal formulations like Androderm, Androgel, Axiron, Fortesta, Testim. A lot of experts I was looking at recommend trying the transdermal form first before the injectables, because it kind of depends on the patient. One reason being it better mimics the diurnal variations of testosterone, so you could apply it in the morning, and that would kind of mimic the peak in the morning, and then as you go on throughout the day, it would be lower as opposed to testosterone, injectable testosterone, which would keep it high throughout pretty much the entire time until you inject again. Kind of depends on where you look as to who recommends what, but that is just one person I was listening to recommended that.
And I guess let's give a couple clinical pearls for some of the formulations that you mentioned, especially if we have pharmacy students or something. So you mentioned a couple of the topicals, so things like Androgel. There's also Testim is another one. But one of the things that's different about those topical gels, and depending on which brand name it is, you actually apply it to different areas of the body. So not all of them are going to be put on the same way. So Androgel, for example, is usually going to be the upper arms or shoulders, but specifically the package insert will say not to the abdomen. Whereas Testim, again, arms, shoulders, but then when you get to Fortesta, which is just the testosterone gel 2%, their package insert tells you to only apply it to the front and inner thighs. And I know there's got to be a better reason than it's just the way they wanted to do it.
Well, one reason I could think of is less contact with people. So, if you applied it to your chest and upper arms and you have your shirt off and your little kid jumps on you for a little bit and you forget about it.
Yeah.
I don't think,
true.
Hopefully they're not going to be hanging around your upper inner thigh too much.
Yeah, we don't want that at all.
I feel like the chest.
We don't advocate for that.
Chest and shoulder might be a little more often.
It's a good point.
And
then there's also the solution. Instead of a gel, it's actually a liquid in case you want to have soaking wet armpits. The testosterone solution is only applied to the armpits. And then the Testo is the nasal gel. So that one
I didn't know there was a nasal gel.
In the nose.
Is that right?
Yeah.
What?
It's it says gel, but I guess it comes as like a spray. But yeah, you have to do it 3 times a day. So it's pretty annoying.
Snort testosterone.
Yeah.
Nice.
Yeah. Thinking of everything now. And then as far as, risks and things like that, obviously, like Cole was saying earlier, the cardiovascular risk, the hepatic, problem, all those things that we always kind of worry about, increased PSA for elder patients who are worried about prostate growth, things like that just kind of have to monitor. It's definitely not something that's contraindicated, but just be aware of it.
Right. And so that's why treatment is patient specific, because hypogonadism in general, if it's age related and it's not due to a underlying genetic condition, that doesn't really show increased mortality. Of course, increased morbidity because you're living with hypogonadism. So it's mainly for quality of life metrics. Obviously, the guidelines recommend getting the level back into normal range, which will hopefully result in improving the symptoms. But if you can, a lot of the men are going to be generally overweight, somebody who's aging, and they're coming in because they feel fatigued, because they're having various forms of sexual dysfunction. And you could say, hey, if you have the symptoms and you have low T and this is something you want to do, use it as a motivator to, hit the gym, lose some weight. Diabetes and obesity are a big cause of hypogonadism. And so the testosterone is not going to be something magical that you give them that's going to help them to lean out and lose weight, but you might be able to work with them to encourage them and motivate them to use that extra energy to do that and hopefully improve the quality of life.
So you're prescribing deadlifts and squats, huh?
Right. Yeah.
There you go.
Given the green, what do they call it? The green prescription?
Yeah, maybe.
Yeah, but exercise. That's what they call it.
The steel prescription. I don't know.
Something. I think it's the green script. I think that's what they say.
Who's they? I don't like those people.
I know. The people. The important ones.
That's true. So, real quick too, and this is one you probably, at least I haven't seen this one too much, the Androderm patch. Have you seen that one a lot?
The patch. I have done the patch, yes.
So,
by that I mean dispense the patch.
Right. Cole is not advocating for testosterone use in someone who's in their 20s. So, like, remember I mentioned earlier with the Androgel, you can't use it to the abdomen. It says specifically do not apply to the abdomen. Androderm, the patch, package insert says, put it on the abdomen. Good to go. So, it's one of those things that just really, you got to be very careful with the application process of these topical and transdermal formulations, because they do, there's several of them and they are very easy to get confused. Yeah. So make sure you double check that. And
of course, the injectables are injections. So your patients will probably want to know that they're going to have to inject, but it might be kind of nice only having to do it once a week. But in general, you're using an actual syringe, and it's not as pleasant as like a GLP-1, Trulicity, where you can't see the needle, or one of those other small ones, or even insulin. It's an actual IM injection. So they should probably be aware of that. But most don't care at that point, I would think.
Yeah.
I do want to mention some drugs that can interrupt testicular function and mimic signs of hypogonadism. So some that interfere with testosterone synthesis, like spironolactone, which they sometimes used for acne, but is mostly used as a diuretic or for blood pressure and heart failure and that sort of thing.
So to mention that too, because that's one of the big things with acne, is because in females it's great,
right?
Males, not so much.
Exactly.
And then the spironolactone, if you actually look at the structure, it looks very similar to estrogen. So definitely not great to be pumping that full of patients for no reason. Just
but
to
if
clear their skin. Blood pressure, though, resistant blood pressure, you go for it.
Right, go for it. But if you're using it for blood pressure and then they're having the symptoms, might be something to consider.
Yeah, for sure.
Also cortisol or steroids in general for long periods of time. Marijuana, heroin, even methadone can interfere with gonadotropin secretion. So something to be aware of.
So don't do heroin, kids.
Also, so we mentioned that diabetes and obesity can lead to hypogonadism. They can also mask it in a way, or not mask it, I guess give a false positive. So for obesity, you might measure like the total testosterone level, and it could be low. There could be other reasons for that. It could be that I'm going to butcher this whole explanation, but basically testosterone is bound to various things, proteins, and I think it's called gonadotropin binding globulin or something like that.
Sounds good to me.
Something along those lines. Either way, in obese patients, they have a lower amount of this. And so when you're looking at their total testosterone, it might be low, even though their free testosterone that's interacting with the receptors is fine, and their testes are actually pumping out regular amounts of testosterone. So if they're obese and they have low T, it might be worth getting some extra labs to look into that. But just be aware that obesity with low T doesn't always mean that they have low testosterone. So if the other labs come back normal, you might not want to actually treat that person.
And for those of you who are into the newest and greatest guidelines, last month, so in January 2020, the American College of Physicians released their new basic guideline, I guess, for treating men with low T. And that was put in the Annals of Internal Medicine on January 6th. So you can actually read it online and look through that if you're interested in that area. But it's interesting because they were advocating for using the testosterone in patients that are having, reduced libido, reduced sexual, any kind of sexual dysfunction, basically, as opposed to, they didn't even really address screening or diagnosis of hypogonadism, or really monitoring testosterone levels just for the heck of it. They were basically treating just that symptom. And when they actually talked about other symptoms, things like, physical function, depressive symptoms, energy, all those things that we kind of think about. And with testosterone replacement therapy, they were kind of saying that clinicians should probably avoid using testosterone treatment and any other concern that population may have that is not sexual in nature, basically.
Right.
So I thought that was kind of interesting. And then they also recommend rechecking within 12 months and to see if it's still making a difference. And if not, they say stop it. And if it is still making a difference, to monitor them frequently after that, but then discontinue if as soon as it stops improving that particular area.
I mean, some people might start on these and say, this is going to be a lifelong situation because, of course I have low T and it's age related, but it doesn't necessarily have to be. And it doesn't mean that they're going to want to be supplementing their entire life. It kind of depends on, it's kind of up to them and depends on how they're feeling in some sense. But not gonadotropin binding globulin, sex hormone binding globulin is what is decreased in obesity frequently and can give a false positive for low T. SHBG.
Gotcha.
That's what it's called.
So the first one sounded cooler though, so.
Yeah, that might be a thing too.
I'm sure it is. Sounded very convincing.
GNBG.
So one other thing we should mention too is one of the things that a lot of the urologists are doing now that I've seen is in patients that are candidates for testosterone replacement therapy, instead of giving them actual testosterone, they've actually been giving them Clomid. So oral Clomid. So that was originally designed to be something to increase fertilization in females and who are actually trying to become pregnant and have babies and stuff. So younger females and all that. So now we see it in men, and definitely if you're a pharmacist, please know that it's very commonly done now. So don't freak out and call the doctor's office. But we see it in men dosed usually 25 milligrams, sometime up to 50. And it's usually dosed daily. And what it does in men is it does still increase your luteinizing hormone, your follicle stimulating hormone, like it would in a female. But again, in the male body, you're usually going to have that surge of testosterone to kind of shut that process down. And so it can ramp up your natural testosterone again, even if it's low originally. And you even see athletes kind of using that sometimes. The ones that are kind of abusing steroids, when they come off of them in order to kind of restart their endocrine system again, they'll get on Clomid. In fact, there's been some MMA fighters who recently got suspended because of Clomid.
Oh, really?
People were like, why are they taking fertilization? And that's
where do they get these things? Like, who gives it to them?
I mean, they realistically, you go to a neurologist and say, I have low T, but I don't want to take testosterone. But like, good for you. Here's some Clomid.
And they're not like, I guess they wouldn't know they're a famous MMA fighter.
Maybe, I don't know. Right. Or if the MMA fighters still get testosterone depletion, unfortunately.
That's true.
There was
but they can be supplemented.
Not anymore. The UFC took that away.
So even if they legit have low T.
Mm-hmm. You used to be able to get a medical waiver for it, but then every single fighter had a medical waiver for it. Right. And they were like, okay. So in fact, I use his picture in my lecture when I talk about this with my PA students, because there's a fighter that was, follow him since I was a little kid. His name's Vitor Belfort. Brazilian guy, a nasty fighter. This guy was like ferocious. Unfortunately, though, and he was getting older anyway, but his doctor believed in a much higher dosing range of testosterone than like a reasonable level. So they were testing his testosterone levels to the point, and they were like, this is insanity. Like, it was so off the charts with the levels. They were like, this is not just replacement. He was yoked. I mean, this guy was enormous, just knocking people out left and right. And then all of a sudden, when they made that rule where they had to stop it and shut it down, he came to the weigh-ins for his next fight. He looked like a completely different person.
Really?
Like, I'll show you the pictures after we get off here. It's like, it sucks. Because you're like, oh no, what happened to Vitor? His testosterone levels are not 4,000 anymore. Yeah, it's crazy, but still a great fighter. But yeah, it definitely does not look the same.
That's funny.
Yeah, that's my MMA story for the day. You're welcome.
Yeah, we get one about every 10 episodes.
Do we?
Maybe every 5.
Ooh, is it that much? I talk about MMA that much? Anyways.
No, maybe not. I don't know. We probably reference, you hurting somebody or something.
I don't know, something. All right, y'all. Thank you so much for listening and the support. And the messages we've gotten over Instagram and emails, and now the text messaging app is probably my new favorite thing. I sent out a secret link to all of them on my text platform, and basically had them. I asked for feedback on a patient case I was working on. Literally, like 40 people text me back like within the first hour with all this good feedback. I was like, this is what's up.
Yeah, that's good. Oh, yeah. I did want to mention one thing before we go.
Yeah.
You don't watch Netflix, do you?
Some, yeah.
Okay. I want to give a have you heard of that new show?
The Pharmacist. Yeah.
Yes. I want to give a shout out.
I have not seen it, but I heard it's really good.
I only watched the first episode, but it's pretty awesome. I'm recommending it. I think it's only 4. It's a docu-series. I won't spoil anything, but yeah, you should check it out.
He's going after like opioids.
Well, yeah,
right?
In the trailer, you see that his son was killed. He was murdered trying to buy cocaine, and he kind of went vigilante justice on him. And then it was revealed that there's this opioid, like the beginning of the opioid epidemic. And he was like, I don't know. He was like, have you seen Taken? Mm-hmm. Okay. You do watch movies.
Yeah.
Good.
Yeah. I watch movies.
I like it. He's like the Liam Neeson
in
Taken for his son.
I gotcha.
But total pharmacist version. Just like
way
AV Club,
less intimidating than Liam Neeson.
Recording all the conversations he has with people. So like the pharmacist version of Liam Neeson and Taken.
Well, there you go.
Yeah.
So Pharmacist starring Liam Neeson. Right. And we should get him on the podcast.
Yeah.
I think we can do that. I bet you we can talk him into it.
Got to go down to Louisiana.
Nah, he's definitely going to Skype in.
Go to New Orleans.
I guess we can go to New Orleans. That would be pretty fun. Yeah. All right. So thank you. Anyways, thank you guys so much for listening. But no, seriously, thank you guys so much. If you ever have questions or suggestions, like our guy Derek did, if any more suggestions like that, send them over email, Instagram, whatever you want to do, whatever's easier. You can text the texting platform there. The number is area code 415-943-6116. You'll get like an automatic response. So just follow that. And then from there, you'll be saved. So when I share stuff with everybody, it'll go right to your phone. But yeah, so definitely. And if you have feedback for us too, we've gotten some of those too. Some nice, some not so nice, but all actually good ideas. So it's good stuff. So we appreciate those too. So anything we can do to make this better, we're trying to really expand our range in 2020. Yes. I don't know what that means, but we're going to get bigger, hopefully.
Expand our range.
Yeah. We're going for an additional 5 listeners. That's our goal.
By the end of the year.
By the end of the year. Cool. All right. Thank you guys so much. We'll see you next time. Bye.